अस्सलाम वालेकुम, मेरा नाम कशफ नीम डार है और आज मैं प्रेजेंट करूँगी व्हाट इज़ मलेरिया एंड द टेबल ऑफ कंटेंट्स आर definition, epidemiology, etiology and pathophysiology, its diagnosis, clinical features and the treatment of the malaria. So the basic definition of malaria is it is a communicable disease which is infectious disease. It is caused by the protozoan parasite from the Plasmodium family. It can be only transferred through the female Anopheles mosquito. When it bites the human, it can cause contamination. And the falciparum malaria is the most deadly type of the malaria. Epidemiology. It has been estimated that more than 200 million persons suffer from this infectious disease. It is the widespread affliction of humans, causes the severe pain, distress, and grief. Malaria is endemic in Asia and Africa, but it also widespread jet travel, and cases now occur all across the world. So the etiology may include five species. The five species are Plasmodium vivax, Plasmodium falciparum, Plasmodium ovale, Plasmodium malaria, Plasmodium noaci. The first two types they are most common and they can cause the dangerous. They are most dangerous and they can rapidly kill the human. Plasmodium ovale, Plasmodium malaria, and Plasmodium noaci they do not cause death, but they can cause severe illness. The pathophysiology include the life cycle of the malaria. So it is a complex plasmodia. It undergoes asexual cycle and sexual cycle. So now I will explain the life cycle of the malaria. So basically, when the female mosquito, Anopheles mosquito bites the human, it releases the sporocyte from its salivary gland, and then the sporocyte travel into the bloodstream towards the liver, and then the immature cells get into the liver. They mature in there, and then they will cause the intrahepatic cells inflammation. Then the inflammatory cells will burst and they will release the merocyte into the bloodstream. When the merocyte is converted into the ring form, it makes the early trophocyte. Early trophocyte will be spreading into the RBC and cause the damage in it and change the RBC shape. After that, when another mosquito will bite the human, the RBC and the gametocyte, which is present in the bloodstream, will go into the mosquito, and the gametes will join and make the zygote, and the zygote will be converted into the ookinete, and the mosquito is again ready to bite the other human to cause the malaria and cause its widespread. So, as I have already mentioned, there are two stages, asexual cycle and the sexual cycle. So, the asexual cycle includes the human infection. When the female Anopheles mosquito inoculates the plasmodial sporocyte from its salivary gland to the human, these microscopic motile forms of the parasite they carried via the bloodstream towards the liver. Then they invade hepatic parenchymal cells, and after the period of time, the asexual reproduction happens. This can cause the amplification process, which is the intrahepatic or the pre-erythrocytic schizogony or mirogony. The single sporocyte can eventually produce 10,000 to 30,000 of the daughter merocytes. So the swollen infective liver cells they will eventually burst into the cells, and then they discharge the motile merocytes into the bloodstream. They can invade the RBCs and they will multiply 60 to 20 every 60 to 20 folds every 48 to 72 hours. When the parasite will reach the density of 50 microliter of the blood, these symptomatic stages of the infection will begin. For example, the cold, fever, rigor. After entering into the bloodstream, merocytes they will rapidly invade into the erythrocyte and they become the trophocytes, as I have already mentioned. Attachment is mediated via the specific erythrocyte receptor, surface receptor. Now, the early stage of the intra-erythrocytic cycle, it is the small ring formed. The four parasitic species they will appear such as the under the light microscopy. As these species, the specific characteristics become evident, like the pigmented trophocytes enlarge in size and it becomes visible. The parasite will assume to be irregular or immobile shape. By the end of the 48 hours, intra-erythrocytic cycle, the parasitic will be consumed by all the hemoglobin and will grown to occupy most of the RBC. Now it is called schizoid. When the multiple nuclear cell divisions they have been taken place, the schizogony or the mirogony of the RBC, it will rupture and release 6 to 30 daughter merozoites, each potentially capable of invading the RBC and repeat its cycle. This disease in human beings, it is caused by direct effect on the RBC invasion and the destruction by the asexual parasite or the host. After a series of asexual cycle, immediately after the release from their liver, the parasite will develop morphologically distinct, longer-lived sexual forms. For example, gametocytes. Now they can transmit malaria to the other humans as well. Now we will discuss the sexual cycle. What is sexual cycle? After being ingested in the blood meal of the biting female anopheles, mosquito, the male and the female gametocytes they will form a zygote, after which they will mature and make the eukaryote, which can penetrate and insist in the mosquito gut wall. The resulting oocytes it expands and causes the asexual division, which will burst into the liberate motile sporocytes. Afterwards, it migrates and the hemolymph to the salivary gland mosquito to await inoculation into the another human for the next feeding. So now I will discuss the conventional malaria diagnostic methods, which can be divided into three categories: microscopy, rapid diagnostic test, and nucleic acid amplification test. So in microscopy, you are supposed to do the blood sample collection. Then you will prepare the thick and the thin smear on the slide. Thick, thick smear will be causing you to know the presence of parasite, and the thin smear will cause you to know about the shape or the species of the parasite. Fix the slide with the methanol, stain it with the gianza stain, and rinse slide with the water and dry, and then observe at the oil immersion in 200x length. Now, rapid diagnostic test will be occurred by the blood collection and then place the drop of the blood into the RDT rapid diagnostic test kits which are available on that strip. Now add buffer on that strip. Now you are supposed to incubate it for the particular amount of time. Observe the control and test lines and then interpret what the results have told you. What is nucleic acid amplification test? You are also going to collect your blood sample, and extract the nucleic acid or RNA or DNA from it. Then add reagent of the for the target sequence application you want to do. Amplify the PCR or the isothermal reaction. Record the fluorescence or the turbidity or the absorbance signal which is being adjusted and interpreted. Quantify the nucleic acid in the sample. So, as I have already mentioned the detail of the microscopical malarial parasitic smear test, thick and the thin smears and erythrocytes will be lysed and all the releasing blood stages of the parasite. It is fast, more blood is used in thick films and facilitate the diagnosis of the lower level of parasitemia. Thin film is essential to confirm the diagnosis to identify the species of the parasite in parasite falciparum infectious, to quantify the parasite load. The advantages of microscopy, their sensitivity is so high so that it can detect malaria parasite at the very low density. It also helps you to quantify the parasite load. It is possible to distinguish different species of the parasite and the different stages. Rapid diagnostic test, it is the detection of the antigens, and it also causes the parasites to be lysed blood. And the immunochromatographic method is basically the concept of the rapid diagnostic test. So the antibody is directed against the target parasite antigen, and this test can be performed in 15 minutes only, and the commercial kits, they are available. The field is evolving rapidly, and technical improvements, they are continually being announced that will undoubtedly enhance the capabilities of rapid diagnostic tests in the malaria diagnosis. So, what are the clinical features? So, it is the most basic knowledge to have is the fever, chills and rigors, headache, myalgia, arthralgia, anorexia, nausea, and vomiting, running nose, cough, or any other sign related to respiratory infection, or diarrhea, dysentery, burning, micturition, or lower abdominal pain, and skin rashes and infections, abscess, painful swelling of joints, air discharge, and lymphadenopathy. These all are the basic clinical features of uncomplicated malaria. So, what if the malaria complicates and becomes worsen? So, the following clinical features are followed in severe malaria. So, severe manifestation can be developed by the protozoan falciparum infection. It is the span of more than 12 to 24 hours, and it may lead to death if not treated. So, impaired consciousness or coma, repeated generalized convulsions because of not treating it. Renal failure can be caused. Serum creatinine level will be greater than 3 mg per day. And jaundice will be occurred if the serum bilirubin is 3 mg greater than 3 mg per day. And severe anemia is HB is less than 5 gram per day. So pulmonary edema can also be the primary cause, or the hyperglycemia, or the circulatory collapse, abdominal bleeding, hypothermia, increased temperature, and hyperparasitemia, increase up to 5% parasitized RBCs. So, what should be the treatment of malaria? So, the treatment of malaria includes following aims. So, we need to completely treat the malaria, prevent the progression of the mild case, and prevent death from the severe or the complicated malaria, and to prevent the transmission of the malaria, and also minimize the risk of the spreading drug resistant parasites, so that effective drug can be used appropriately in appropriate dosages for everyone. So non-pharmacological treatment include the exchange of transfusions. It is controversial in insufficient evidences. So non-immune patients with the severe falciparum malaria should be given vaccinations. Volume expansion, like in malaria, you are supposed to give a volume of liquids like sodium chloride and albumin, provide organ dysfunction and acidosis. So, hemodialysis or peritoneal dialysis can also be done to the patients who have developed renal failure. Pharmacological treatments are following: 4 aminoquinones, for example, chloroquine, amodiaquine, hydroxychloroquine. 8 aminoquinones are primaquine, pamaquine, pentaquine, isopentaquine. 4 quinoline methanols: quinine, quinidine, mefloquine. Phenanthrene methanol, halofentrine. Artemisinin derivatives are artemisinin, artemether, artesunate, arteether. Antimetabolites will be proguanil, pyrimethamine, atovaquone, dapsone. Antibiotics will be tetracycline, doxycycline, minocycline. Diaminopyridines will be pyrimethamine. So I will discuss each and every single drug with you. Artemisinin derivatives. The mechanism of action is that it inhibits the protozoan falciparum species, encoded the sarcoplasmic and endoplasmic reticulum calcium ATPase enzyme, and then it causes the heme metabolic pathway inhibition. It is the fastest acting antimalarial drug available in the market. It also inhibits the development of the trophozoite, then it prevents the progression of the disease. Young circulating parasites, they are killed before even they are sequestered in the deep microvasculature. The mechanism of action is started before 12 hours of administration. So the uses are complicated P. falciparum malaria. It can also be effectively used in chloroquine resistant strains of P. falciparum. So the major adverse drug reactions occurred by the use of artemether or artemisinin derivatives are neurotoxicity, nausea, vomiting, anorexia, dizziness, neutropenia, anemia, hemolysis, elevated levels of liver enzymes. So, what will be the dose? So, the artemether should be injection of 3.2 mg per kg intramuscularly, and the artemether should be 3 mg per kg once a day for 3 days, as deep as IM injection. Artesunate should be the 4 mg oral dose or the IV injection dose of 2.4 mg per kg, followed by the 2.4 mg per kg after 12 hours or 24 hours, once daily after thereafter. So the second drug is chloroquine. Mechanism of action would be alkaline. The drug reaches the higher concentration within the food vacuoles. So the parasite and it raises its pH. It is found to induce rapid clumping of the pigment. So the chloroquine it inhibits the parasitic enzyme heme polymerase. Then it converts the heme into the non-toxic hemozyme. The accumulation of toxic heme within the parasite will lead to the infection, and it interferes with the biosynthesis of the nucleic acid. So the uses are for all the five species: P. vivax, P. ovale, P. malaria, P. sensitive strains, P. falciparum, and the gametocytes of P. vivax. So the patient should be given in the acute attack of malaria within the afebrile range of 24 to 48 hours of infection. It is more effective and safer than the quinine in the safer and the sensitive cases. Now the areas related to the drug are dizziness, headache, distributed visual accommodation, dysphagia, nausea, malaise, pruritus of palms, soles, scalp, visual hallucinations, confusion, occasionally they frank psychosis. So contraindications. This drug should not be given with the patient hepatic with the hepatic disease and the severe gastrointestinal bleeding or disease, or any of the neurological disease or the blood disorder. So the oral dose of the drug is 4 mg per kg, and then the three doses of 5 mg per kg over the 36 to 48 hours. Quinine. So quinine it acts on the blood schizontide. It also called as the gametocidal activity against the PVVX and the P. malaria. Because it is a weak base, so it is concentrated into the food vacuoles of the P. falciparum. It also acts by inhibiting the heme polymerase. That the accumulation of the cytotoxic substrate heme is inhibited. As the schizonticidal drug, it is less effective and more toxic than chloroquine. So it is used in the management of the severe falciparum malaria in areas with the known resistance to chloroquine. So the quinine drug related adverse effects are mild synchronism and the ringing in the ear, headache, nausea, disturbed vision, neurotoxicity, night blindness, blurred vision, disturbed color perception, vomiting, abdominal pain, diarrhea, and hypoglycemia. So the drug should not be given with the a patient with the tinnitus or the optic neuritis, and it should also not be given the patient with the atrial fibrillation or myasthenia gravis. The doses are 10 mg per kg every 8 hours for 4 days, and then 5 mg per kg every 8 hours for the 3 days. If you are going for the intramuscular injection, then go for 20 mg per kg stat and followed by the 10 mg per kg orally deep IM injections for 5 to 7 days. So the chlorguanidine proguanil drug, it acts as the antimalarial action by inhibiting the parasitic dihydrofolate reductase enzyme. It is the casual prophylactic activity and suppress the activity of P. falciparum, and it also cures the acute infection. It is also effective in suppressing the clinical attacks of vivax malaria. Chlorguanidine It, along with the chloroquine, is used as prophylaxis effectively against P. falciparum malaria. So, occasionally, nausea and diarrhea, 100 mg to 200 mg doses are used. So the drug number 5 is sulfadoxine with the pyrimethamine. So it comes with the combination, and the pyrimethamine, it inhibits the dihydrofolate reductase enzyme of the plasmodia. So it does block the biosynthesis of the purine and pyrimidine and the basic structures of DNA synthesis is inhibited, and the cell multiplication is also inhibited. So this can lead to the failure of the nuclear division, and as a result, the time of the schizoid formation, the erythrocytic or the liver is inhibited. So sulfadoxine inhibit the utilization of the PABA in the synthesis of the dihydroteric acid. In the combination of the pyrimethamine and sulfadoxine, they also offer two-step synergistic blockade as a plasmodial deviant. So the drug should not be given with the agranulocytosis or the aplastic anemia, hypersensitivity reactions, vomiting, or the acute hemolytic anemia. So the drug should also not be given in the case of hypersensitivity of the sulfa drugs or infants below 2 months of age, and the patients with the advanced renal disease or the first or the last trimester of the pregnancy is not safer for the use of this drug. So the next drug is halofentrine. Halofentrine is the drug which is causing its mechanism of action by the exact same mechanism of action of chloroquine, quine, or mefloquine. So they form the toxic complexes within the ferritophyrin 9. It causes the damage of the membrane of the parasite. This will lead to the antimalarial effective activity, and it also acts as against the multi-drug resistance, mefloquine resistance, and it is used for the treatment of the chloroquine resistant or the multi-drug resistant or for the uncomplicated P. falciparum malaria. The areas of these drugs are abdominal pain, diarrhea, prolonged of the QT interval, and the arrhythmias that could be fatal. So this drug should not be given in the pregnancy, lactation, infants, patients with the received mefloquine in the preceding 3 weeks. It can cause the interactions. For the adults, 5 tablets should of 500 mg should be given each 6 hours apart, and then in the children, 3 doses of 8 mg per kg should be given as the salt form in every 6 hours. Treatment should be repeated after 7 days to prevent the further infection. Mefloquine is the drug which is used to produce swelling of the P. falciparum food vacuoles. In that way, it causes the toxic complexes within the free heme that damages the membrane, and it also interacts with the plasmodial components. Then, as a result, it is the effective against the blood forms of the falciparum malaria. It includes the blood forms of chloroquine resistance type. Mainly, it is used for the P. falciparum malaria. So the adverse drug reactions related to mefloquine are nausea, vomiting, abdominal pain, dizziness, sleeping disturbances, ataxia, sinus bradycardia, postural hypertension, seizures, and psychosis. Mefloquine should not be given with the patient in prophylaxis in pregnancy, particularly in the first semester, because it is contraindicated with the patients with a history of seizures and severe neuropsychiatric disturbances. So the dose of 15 mg per kg in the single dose should be given. The dose should, if it exceeds 1000 mg, the second dose can be given after 4 to 8 hours to minimize the gastric irritation. Drug number 8 is atovaquone. So the drug acts on the lipophilic molecules, supposedly interfere with the mitochondrial electron transport, and then thereby the ATP and the pyrimidine biosynthesis is inhibited, and in the plasmodia, and it is found to target the cytochrome cell complex, and it also disrupts the membrane potential. Now the atovaquone use as a combination of proguanil and atovaquone and proguanil. Now approved for the both treatment of prophylaxis of anemia, malaria. So the areas related to these drugs is the rash, fever, vomiting, diarrhea, headache, safety in pregnancy, lactation, children, and elderly people. So the dose should be 250 mg of ataquine plus 100 mg of proguanil per tablet, as if it comes in combination. Or the other dose should be for children is 62.5 mg atovaquone to 25 mg proguanil for per tablet. So now I will conclude the whole lecture. So the summary will be concluding malaria is treated by the guided of the species. It varies with the species. Combination therapy is required to help the eradicate the parasite and also prevent the development of the resistance to the antimalarials. Patients who have malaria and they are treated according to the causative parasite, they are generally those with the Plasmodium falciparum infection, experience a more severe illness and should receive treatment in hospital. Thereby they can be monitored closely. Patients with the non-falciparum infection, they can also be treated as outpatients. Oral quinine, they comes with a combination of doxycycline or clindamycin to prevent infections further. Malarone or Rahmat, they can also be used for the treatment of non-severe P. falciparum infection, so that the intravenous quinine or the artesunate, they can be reserved for the severe or the complicated illnesses. And the non-falciparum infection, they can be treated orally with the chloroquine and the relapse prevented using primerquine. Thank you so much for watching this video. Kindly like, comment, share, and which topic would you like to discuss further? Comment below.